to talk just a few minutes about the changes and discomforts associated with pregnancy. One thing that I want you to do is I want you to take a look at the pictures on this slide and realize that so many of the changes that take place can be hormonal, but they can also be related to the size of the fetus. For example, we have a 7-week-old fetus here, and you can see there's very little change in the anatomical structure of the mother. And then as things get a little bit bigger, and then even bigger, you can see that things begin to get shifted and infringed upon, and that can cause a lot of our problems. So if you take a look at that, then you'll know. Over here you have what's called a linea nigra, so you'll see some physical changes. You may see more hair, you may see less hair, but this is hormonal and it will go away. This is a little growth called an epilis on the gum, and it goes away after pregnancy as well. We tend to have some fluctuations in vital signs, but most often the vital signs should stay very close to what they were prenatally. So whenever you take a pregnant woman's vital signs, you want to be sure to ask her what her pre-pregnant vital signs were so that you know if they're running higher or lower. Some of the discomforts of pregnancy include nausea, exhaustion, back pain, constipation, heartburn, vomiting, incontinence, varicose veins, moodiness, and stretch marks. Gotta love being pregnant. Here's some other ones. Might include some edema. We hadn't really talked about that. But we'll talk about these, and I want to talk about them in a little bit different format than maybe you're accustomed to. I want you to think nursing process. So, for example, nausea and vomiting. We're going to choose here the nursing diagnosis of alteration in nutrition, less than body requirements related to hyperemesis. Now, is this the only nursing diagnosis that could go along with this? Of course not. But you have a list of nursing diagnoses included in your syllabus and posted on Blackboard, and this is the way that you need to be thinking. Could we have an electrolyte imbalance? Of course. Could we have dehydration related to hyperemesis? Of course. But let's keep all of those in mind, and let's look at what your supporting data might be. Your supporting data is always what you will find on assessment. Our scientific rationale for these changes: hormonal, a decreased gastric motility, and also emotional fears. You can come up with your goals. Here, you would have no alteration in nutrition, and then you can look at your as evidence bias that may include things like no more nausea and vomiting, a stability or an increase in weight, a stability or an increase in appetite. Those kinds of things could be as evidence bias that point towards your goal. Strategies here include small frequent meals, fluid between meals, avoid spicy or greasy foods before rising, eat small portions of dry foods, and then you would evaluate how your patient or your client is progressing. And that's basically the gist of nursing process. So let's take a look at these other discomforts related to that. Fatigue. One I chose was activity intolerance related to fatigue. Could it be other things? Of course it could be. It could be an alteration in lifestyle, role changes within the family. It could be a number of things. But here I just chose activity intolerance because it was the obvious one that went with this. You would have your supporting data again, and your scientific rationale is that the BMR, the basal metabolic rate, increases in pregnancy. You can also have inadequate nutrition. Gee, where would that come from? And poor sleep due to stress. Your goal would be that maybe there won't be any activity intolerance. And your strategies include things, and this is not all that it would include, but things like increased protein and carbohydrates, good body mechanics, regular exercise, frequent rest periods, and even for mom to vocalize her feelings of what's going on. And again, you would evaluate your client of how they're coming along, and then you would change any strategies or adjust the nursing diagnosis as needed. Varicose veins. The one I chose was alteration in circulation related to venous circulation backing up. Your supporting data, you saw a picture earlier of what that looks like. Scientific rationale is you have the relaxation of smooth muscle walls of veins and legs due to the hormones, and a large uterus slows down venous return. Your goals: Self-explanatory, your strategies. You would have mom avoid standing for long periods of time, wear support stockings, rest with legs elevated, avoid constrictive clothing, and then evaluate. Now let me again point out that varicose veins are not limited to pregnancy. This is one of those things that you cannot put in a box, as well as many of these other discomforts. So let's say that we're addressing alteration in circulation and varicose veins in somebody who is just a client on your med-surg unit. These strategies don't change. We do the same thing. Same thing with nausea and vomiting. We don't change the strategies. So quit learning in a silo and begin to put these things across the continuum of care. Increased vaginal discharge. I said risk for perineal infection related to increase in discharge. And it's a risk for because it hasn't actually happened. Remember, you can always have a risk for. Scientific rationale. We have an increase in estrogen, and the cervix begins to hypertrophy. Strategies might include bathing daily, good perineal care, wearing loose-fitting clothing, maintain hydration, those kinds of things. One thing you would not want to do is you would not want to suggest douching, because douching can introduce bacteria and whatnot up high into that vaginal vault and even into the cervix, even though there is a cervical plug. Hypotension, the blood pressure dropping. Here I didn't do anything with circulation. I could do circulation, alteration in circulation, but I chose to go a different route, and I said risk for injury related to decreased in blood pressure. What causes this? You have a pressure of the uterus on the vena cava, which can result in that decrease in blood pressure. So you're going to rise slowly and avoid standing for long periods. Hypotension is hypotension. Again, it's not necessarily related to pregnancy. We do see it more in pregnancy, but it's not necessarily related to that. Constipation, again, constipation could be here, I said alteration and elimination related to slowed digestion. Could it be alteration and elimination, constipation related to maybe taking narcotics or not drinking enough fluid in the diet? It could be a lot of things. Scientific rationale here with pregnancy is that there's slowed digestion due to the progesterone. Mom is also taking iron supplements. There's a pressure of the uterus on the colon if you go back and look at those pictures. And also maybe a reduction in exercise. With exercise, mom needs to be doing what she's been doing. This is not the time to train for a marathon unless she already does marathons, but moms need to keep moving. Strategies: increase raw vegetables, whole grains, regular bowel schedule, increase fluids, and of course exercise, even if it's getting up and walking after dinner. Now hemorrhoids are basically a varicose vein of the rectal area. I chose pain related to the presence of hemorrhoids. Scientific rationale: it can come and run in families. It is a relaxation of the smooth muscle wall of the veins in the rectum. They are painful. They can be itching, and also because of pressure of the uterus and baby on that area. Strategies: we want to avoid constipation because that will just increase the pressure when having a bowel movement. Increasing fluids and fiber, and avoid constrictive clothing or sitz bath. Again, this is not related just to pregnancy. We do see it frequently, and that's why it has a tendency to put in with this content. Are there other nursing diagnoses that you can come up with related to hemorrhoids? A backache, alteration in comfort related to lordosis, or the sway back. Remember, the center of gravity changes in a pregnant woman, and they tend to get a sway back. Why? You have the relaxation of the symphyseal and sacroiliac joints and a change in the center of gravity. There's also a hormone that is secreted called relaxin, and what that does is it begins to relax the joints to make childbirth more easier, and so that mom's body can change to whole baby. So another one you might want to think about with this, it could be maybe a risk for injury related to backache, or a risk for injury related to the change in the center of gravity. So you can see a lot of nursing diagnoses can surround this. Strategies include good posture, exercise such as pelvic rock, pelvic tilt, tail or sit, low-heeled shoes, pillows for support, and always maintain good body alignment. Again, you will evaluate and you will change as you need to. Dyspnea or shortness of breath. Supporting data will be based on what you find on assessment. The fetus begins to put pressure on the diaphragm. Strategies: rest with the upper body elevated and maybe avoid exertion, though again moms do need to keep moving. Leg cramps, pain related to a muscle cramp. Could it be alteration in movement or something like that? Of course it could. Scientific rationale: increase in uterine weight. Remember, we should only gain about 25 to 30 pounds, maybe 35 max with a pregnancy, and most of that should be related to the uterus and baby and not overall weight gain. Increase in circulatory load, inadequate rest, and imbalance of calcium to phosphorus ratio. All of those things result in leg cramps. Strategies: you're going to check the Holman sign because we are always concerned that there might be a blood clot in there. You can dorsiflex the foot if a cramp occurs, evaluate the calcium in the diet, and elevate the legs. Swelling or edema. I chose alteration in circulation related to swelling. Again, there are others that you could use. Increase the circulatory load, and you have slower venous return, and you can have some normal swelling in the day, but it should be that when those feet are elevated, that swelling should go away. Strategies include elevate the legs and avoid tight clothing. Notice one of the strategies is not to avoid drinking fluids. That's not the problem here. You do need to maintain hydration. Heartburn, risk for alteration in nutrition, less than body requirements related to discomfort when eating or heartburn. Sometimes when people get heartburn, they just don't eat. And I've got a baby that's pushing on the stomach, pushing on the esophagus. That can result in heartburn. Could I use pain? Yes. Are there other ones I could use? Of course. Why do we have this going on? Because there's a relaxation of the esophageal sphincter and a compressed stomach due to the presence of hormones and also to the presence of the fetus in that area. Strategies. Again, these strategies apply to heartburn on anyone, pregnant or not. Remain upright after meals, elevate the head of the bed, have a diet low in fat and caffeine, which can aggravate it, and drink and eat small, frequent meals. I want you to notice her plate. Her plate is full of nutrition because there's lots of colors on that plate. So you've got to have nutrition despite the discomfort. Nutrition in pregnancy, again, please note that we have lots of color on her plate. And pretty much if you can eat the colors of the rainbow, you've got good nutrition. Recommended weight gain, about 30 to 35 pounds, though research is beginning to show we don't need to do that much. The pattern of weight gain, about a pound a week, maybe a little bit less. Distribution of the weight, you don't need to memorize all of the distribution of the weight, but the vast majority of the weight should be in the baby and the size of the uterus and maybe some extra circulation that will be eventually diuresed off. It shouldn't be any 70 pounds. That's not baby. That's just eating and accumulating just overall body fat. Only need to increase the diet about 300 calories a day. 300 calories. That's it. That's about what a lean cuisine's worth. Not this huge amount of food that people think that we need to eat when we're pregnant. Nutrients, protein, calcium, iron, and folic acid. Foods you want to avoid. You want to avoid caffeine. However, people don't want to come off of caffeine cold turkey. Most of the time it gives them a big headache. But if we can get them to decrease caffeine, maybe come off of it, that would be an excellent choice. Another thing, not just artificial sweeteners, but you might want to suggest against anything artificial. If it looks like a chemistry experiment, it probably is. Exercise, as we said earlier, moms are free to exercise. They just don't need to be start training for a marathon. They need to keep moving, maybe a walk after dinner or something like that. But if they have been moving, they need to keep moving. Benefits, they're going to go through labor easier. Labor is hard work, plus they'll be able to be in better shape to carry this baby. Guidelines, like I said, if they've been doing it, they can keep doing it. Medications, mom will be taking multivitamins, iron, folic acid, and antacids. Some moms, as far as multivitamins, might be a Flintstone vitamin that is recommended. Regardless, we need to increase these things. Folic acid is for neurotube defects. We find that there is a direct correlation about taking folic acid and a decrease in neurotube defects. And last but not least, just to touch momentarily on childbirth education. There's informal, in other words, the stories that are told, and formal. There are all kinds of classes, from Lamaze classes to breastfeeding to sibling classes. And the thing is anybody can be a teacher. Anybody. You don't have to have a special certification. Those certifications are available. Content, like I said, anywhere from breastfeeding to Lamaze to exercise to nutrition. I've taught childbirth education classes. We covered anesthesia, stages of pregnancy. We had the physician come in. So it just depends on whoever's doing it and how they want to run it. So again, nursing care plan. That's the way to think. That's the way you need to start thinking.